Welcome to the Microwave Medic. This is Jim Hoffman, your EMS tips chef, and I'll be giving you some quick tips on a variety of topics that you can use right now as an EMS provider that are sure to be the recipes for your EMS success. Microwave Medic is produced by EMS Office Hours, the live online podcast for EMS professionals. Hey, Jim Hoffman here from EMS Office Hours and the Microwave Medic, and this quick presentation we're going to talk a little bit about needle decompression, and more importantly we're going to talk about the landmarks and the procedures that are commonly used for decompression of a tension pneumothorax. Now, of course, you're going to follow your local protocols and what you're allowed to do in your region, but these are pretty common steps. And you might deviate a little bit from where you are, but more importantly, I want to just kind of go over some of the signs and symptoms and landmarks and things like that, because this is what we are often tested on at skill stations, things that we're asked to recall when it comes to exam taking. And of course, when it comes to patient care, we don't want to start thinking about these procedures at that time. We want to be sure that we have these pretty solid in our minds and what we want to do for these patients. So what are the first thing we're going to want to do? Of course, we're going to make sure that the patient actually has to have that needle decompression. We're going to confirm the need. We're going to make sure that they have to have it. And in order to do that, we want to make sure that their respiratory distress, which can include things like shortness of breath, maybe they're breathing too fast, cyanosis, even chest pain, and also things like tachycardia, signs and symptoms of shock as well. Also, things you want to look for when you're trying to decide whether or not a patient really needs to have needle decompression. You're going to look for absent or decreased breath sounds on the affected side for the patient. Okay, you want to look for it on the affected side. And you hear a lot about deviated trachea, and that's going to be away from the side of the injury. The thing just to mention on deviated trachea, a lot of times we hear that a lot, and that's one of the things we kind of regurgitate when it comes to testing. But in the field, in reality, this is really a late sign of a tension pneumothorax. You're not really going to see that in the field. A lot of times, if you do see it, it's going to really be more sort of the substernal notch areas where you're going to actually see that, because a lot of times, even in trauma rooms, even the late sign when it actually happens, we don't get to see it in the field, and a lot of times you only can really see it if it gets confirmed on an x-ray, okay? Because what happens is this happens a lot of times behind the sternum, so you might actually be able to even feel it or see it anyway. So try to focus more on the patient presentation overall and their signs and symptoms of respiratory distress, and for that decreased or absent breath sounds. Okay, so some things, of course, high con oxygen. That's one thing we want to do, of course, for all of our patients, especially these types of patients, because they might be becoming hypoxic due to this pneumothorax. And you're going to identify that second intercostal space on midclavicular line, and we hear that a lot. Second intercostal space, midclavicular line, and this is on the same side as the pneumothorax, that affected side. And of course, you're going to cleanse the site with povidone or iodine solution before you do the puncture. So here's just a quick picture, just to give you an idea of that second intercostal space. So we hear it a lot, and a lot of times it's not exactly explained clearly enough where that is, and it can be some confusion to that. Here's a little bit of a cutaway, and you can see you've got the second and third rib, and then there is your second intercostal space right there. Okay, it's right here is where you're going to be going. All right, and you're going to be directing that needle right above the third rib here. Now, you're going to use normally a 14 gauge needle, usually between 3 to 6 centimeters long. This is for your adult patients. Pediatric patients, you can use an 18 to 20 gauge needle, probably 2 to 4 centimeters long for a child or infant. Of course, patient size is going to determine how long the needle is and which gauge you're going to want to use for child or infant. But for our adults, it's going to be 14 gauge needles, 3 to centimeters long, and these are over the needle type catheters, because these are going to be the ones where you're going to put it in and you're going to wind up leaving that catheter in the patient and removing the needle. Okay, and you're going to insert that. Again, it's going to be above that third rib that I showed you on the previous slide. Let me just go right back to that. Right above here is where you're going to be inserting it. And a lot of times you can't see this on patients, especially heavier patients. So you want to use your landmarks, okay, using your clavicle landmarks, and try to count the ribs down that way. So you're going to insert that 14 gauge needle over the needle catheter into the skin. It's going to be just above that third rib like on that previous slide, and you're going to direct it into the interspace there. And here it is, another demonstration here showing you exactly where you're putting it in. And this is because you've got a lot of nerves, a lot of vasculature there, so you want to make sure you go over this rib. This is going to be the best position in order for you to decompress the patient. Now, you're going to insert it in that location, okay, right through the parietal pleura until you're going to hear air exit under that pressure. You'll hear it hissing out most of the time, and once you do, you can go ahead and remove the needle, leave that cannula that we mentioned in place, okay, and normally you're going to leave it there until it's replaced in the emergency room by something more efficient. And keep in mind that this is going to be secured for transport. You can secure that cannula there, and make sure to attach your flutter valve as well to the end of the cannula also, so air doesn't going back in to the patient's space. So a lot of time we use the end of a glove, something like that, in order to use it as a flutter valve. But there are more commercial devices out there nowadays you can get that are much more efficient than a flutter valve, and actually lets you control it better, actually lets you secure the entire cannula much better as well. Here's a quick picture of sort of a kit that's out there that you can use. Now, of course, we have the needle, the syringe, and all that for the air escaping, but we've got this nice little plastic tubing here with a stopcock on it, and here is your flutter valve, and this right here is sort of like a rubber band type thing that you can see will flutter when air goes in and out, and this is what kind of keeps it from going back into the patient. So pretty cool device, and you would secure this tube and this here plastic device to the patient's chest so you can monitor it and you can see what's happening to the patient. So this is a pretty cool kit, very, very easy, self-explanatory. Pretty much everything we already use, you know, our tape, our iodine and alcohol and syringe and all that. The only additions here really is the more commercial flutter valve device here and this tubing that allows you to really secure it well to the patient and be able to monitor what you did as far as the decompression. So listen, I hope you can use these tips. Again, this is a quick overview I hope you can use in the field, and I hope that it's just sort of like a quick reminder for you for your skill stations, for your exams, and you know, when you're being questioned on these things. And more importantly, I also hope that it helps you should you get a patient with a tension pneumothorax, that you won't focus so much on looking for that tracheal deviation, and you'll focus a lot more on the patient's clinical presentation and how they're presenting to you as far as their signs and symptoms, difficulty breathing, things like that, and keep that shock mentality in your head too, because that's also a sign that you've got the pneumothorax going on. Also, it's probably a much more clear sign than you're going to get waiting for tracheal deviation. So I hope you can use these minutes here in your daily activities. And if you have some microwave minutes you'd like me to go ahead and present here at EMS office hours, be sure to send them over to me. It's jhoffman@ems-safety.com. Be more than happy to try to work some presentations in here on something you want to see or you think might help you out in the field or in your testing. In addition, don't forget turbomedic.com, which is a premier service we have at EMS office hours, and this is a monthly service we offer to enhance your knowledge base, help you with testing skills and continuing education. So go check that out at turbomedic.com. Well, that's it for me. This is Jim Hoffman from the Microwave Medic. As always, guys, stay safe.